Ladies and gentlemen, colleagues and friends, I would cordially welcome all of you to attend this China-dedicated session on advancing renal denervation in China from guidelines to practice. In this session, and I would give a short 10 minutes presentation updating the use of renal denervation in the management of hypertension in China. Then we would have two cases, presentations and discussions. So then I hope you may enjoy this session and participate in the discussion. So my name is Jiguang Wang. I'm from the Shanghai Institute of Hypertension Region Hospital, Shanghai Jiao Tong University School of Medicine. And we have distinguished scientists and physicians, cardiologists from China. So we have Professor Yu on my right hand from Lanzhou University, northwestern part of China. And we have Professor Lu Chengzhi from Tianjin, a big city near Beijing. And on the very right side, Professor Zai Guangyao from Beijing Luhe Hospital, which is a affiliated hospital of Capital Medical University. And on my left side, Professor Li Yingxiang from Maikei Memorial Hospital from Taiwan. And then on the left side, Professor Xue Yajun, also from Beijing. He's from Tsinghua Changgeng Hospital, which is also a teaching hospital affiliated to Tsinghua University. And we have a presenter, Dr. Xiong Tian Yuan. She's sitting in the audience, and she will present the first case of this session. So then we would immediately start the first presentation. Then I would give the presentation on the latest update on renal denervation in China. That's my disclosure. So I would very briefly discuss about prevention and treatment of hypertension in China, then discuss about the safety and efficacy of renal denervation in the Chinese patients with hypertension, mainly present the recently analyzed GSR-defined China data. So here you see in China, the prevalence of hypertension increased substantially in the past about 70 years, from about 5% to the current 28%. And in the past about 30 years, the control of hypertension improved a lot. You see from the very low control rate, around 2%, to the current close to 20%. And if you look at the comparison between countries, and we still have very big room for improvement, hopefully in the next few years. And then if we look at the recently published Chinese hypertension guidelines, you see that this new Chinese guideline document recommends the use of renal denervation in the management of hypertension in those patients with resistant hypertension or difficult to control hypertension, either because of treatment adherence or intolerability. And in China, we have worked with the simplistic spiral catheter in the treatment of hypertension about 2 years ago in Hainan Hospital, in Hainan Region Hospital. And now we have the spiral system approved in the management of hypertension in the whole country. So we started the use of this system in our clinical practice since about a year ago. So here I would mainly present the data collected in the GSR-defined China cohort in the past about 2 years. So we have altogether 54 patients enrolled from our hospital and from several other hospitals across the whole country of China. So here you see the outline of the participating countries of the GSR-defined study. And so this study typically used the simplistic spiral catheter for renal denervation in patients with hypertension. Then if we look at the baseline clinical and demographic characteristics of these 54 patients enrolled in this China study, you see on average they are quite young, 45 years of age, and many of them are men, and also quite obese. On average, body mass index was 27. In China, we still use this threshold for the definition of obesity. So we have a lot of smokers. If we look at clinic and 24-hour ambient blood pressure, you see many of them had a high clinic systolic and diastolic blood pressure, and also ambulatory 24-hour systolic and diastolic blood pressure. And we did renal denervation in all these 54 patients without many complications or any adverse events. Only one vascular complication not related to the procedure directly. So that's the most important data from this China study. If you look at the clinical blood pressure reductions, so you see it's quite similar to the overall global cohort. So on average, about 20 millimeter mercury reduction in clinical systolic blood pressure, around 10 millimeter mercury and diastolic blood pressure. But if we look at ambient blood pressure reductions, either for the 24 hours or in day and night time, you see actually the Chinese had slightly greater reductions for 24-hour ambient blood pressure and also for the nighttime blood pressure. So probably this renal denervation procedure deals with some mechanisms in the blood pressure regulation or dysregulation in Chinese patients with hypertension or the patients from Eastern Asian countries. We have high dietary sodium intake, and we probably are also more salt sensitive. And then we look at the control of hypertension in these 54 patients. As you see, we actually achieved the target of blood pressure control in close to 80% of those patients for systolic blood pressure. And if we look at 130 and 140, the two levels of targets, then you see many of them actually achieved a more intensive blood pressure control, which was defined as 130 millimeter of mercury. So this procedure really treated and cured many of those patients with uncontrolled hypertension. So when we look at the use of antihypertensive medications, you see here on the left hand at baseline, and on average 2.7 medications at the 6 months follow-up, reduced a little bit to 2.5. It's not statistically significant, but on the right hand, if you calculate the burden of antihypertensive medications, and you see a statistically significant reduction, which was approximately by 1. So this procedure in the Chinese patients with hypertension significantly reduced clinic and ambulatory blood pressure, and with significantly reduced burden of antihypertensive medications. So finally, I would acknowledge the contributions of our colleagues from Regent Hospital and from several other hospitals across the whole country of China. So finally, I would say that probably this procedure would help us a lot in achieving the control of hypertension in the next few years. Actually, some years ago, we set up a goal of 50% of control rate of hypertension in China from the current 20%. So it is a very ambitious goal, but I believe with the development of the new technologies and innovative antihypertensive treatments, and we can achieve a much higher control rate of hypertension in the most populous country of China. Thank you. Thank you very much. So then I would invite Professor Xiong Tianyuan to give the first case presentation. Dr. Xiong, please.
So good afternoon. I'm giving this presentation on behalf of our leader, Professor Peng Yong, who is the leader of our RDN program in our hospital. He has another hospital service that he must attend, so I'm giving this presentation on behalf of him. So the patient that we previously dealt with, she is a female, 36 years old, who is relatively young, with a BMI over 28. She has been diagnosed with hypertension for 6 years, so it's at a relatively young age. And she has experienced a hypertensive emergency with an office blood pressure over 200 and over 110, and with a relatively fast heart rate. She's also complicated with type 2 diabetes, and she has been diagnosed with type 2 diabetic autonomic neuropathy. She has actually experienced transient ischemic attack previously with documented hypertensive retinopathy. And she, because of at this relatively younger age with a lot of comorbidities, she has been in an anxiety state, which she kind of complained of in a fear of going to die at a relatively young age. And because of anxiety state, she cannot sleep well. So at this patient profile, we see a young female with a lot of comorbidities and not very healthy mental status. So we give him consultation in outpatient clinic. And after a review of history, this is a list of antihypertensive drugs that she has been taking when she came to our outpatient clinic, and you can see it's a long list and of hypertensive medications. The burden is huge. And she also take other medications for her diabetes and anxiety. So what we are going to discuss is what can we do for a potential RDN patient. And we will discuss our group approach to identify the right candidates for RDN in our daily practice. So this is our patient's office blood pressure and her result of 24-hour ambulatory blood pressure and heart rate. So we underwent a thorough lab and imaging tests, which would give some key measurements and some results to you. And this is some laboratory tests with her liver and kidney function and the lipids profile and pro-BNP level and the thyroid profile. And because she was diagnosed with hypertension at the age of 30, so we also did an ARR ratio to rule out some secondary hypertension. So in face of such a young patient with a very huge burden of antihypertensive drugs, this is a flow chart that we kind of follow according to the guidelines produced by Professor Wang Jiguan. So that's also something that we try to stick to for diagnostic evaluation for hypertension. And this should also be followed as a basic for potential RDN patient selection. So in summary of our patient's diagnostic evaluation, she has a grade of blood pressure, grade 3 resistant hypertension because of all those drugs that she took. The cause of hypertension, we believe it is primary hypertension because we have ruled out hyperandrogenism and Cushing syndrome and renal or renal artery disease. And she has a combination of many risk factors for potential future cardiovascular events. So after giving the patient profile, I would like to invite all the audience here to vote whether you would choose to offer an RDN therapy to her. So please join us to give your vote. Okay. Okay, good. So now we see a huge proportion of our audience who votes for yes for an RDN therapy. So we go back to the patient's story. After a discussion with her of what we can offer her and solving some of her questions to the procedure, we offered her the choice of an RDN procedure. And for this procedure, we did some pre-procedural planning on her anatomy, her kidney function, and we, of course, discussed her preference with him. And we also kind of discussed with whether she will be responded to the therapy or not. So after all these workup and discussions, we offered her the RDN approach. And these are the intraprocedural images. We did both renal arteries and on the ablation points. So this is the change of her office blood pressure and the change of the medication that she took before and after the RDN therapy. So she has been followed up for more than 2 years, for more than 4 months. At very recent follow-up, so it's last month, her blood pressure is stable to 110/78 millimeters of mercury without any medications. So we thought this is a very good presentation of what our patients with resistant hypertension can improve and can receive after an RDN approach. And to be more specific and in details, the change of her 24-hour ambulatory blood pressure is shown on this slide, with a change of the type of medications that she took. Our group's approach to identify the right candidates for RDN in our daily practice include, of course, a comprehensive evaluation for better hypertension diagnosis. That means we will go through all the medications and to work up for the patient's liver and renal function, and to identify any hostile anatomy to offer this procedure, and of course to rule out any potential other secondary reasons for hypertension. And we also developed an RDN team within our group, including interventional cardiologists, hypertension experts, and our colleagues from the endocrinology department, and of course our anesthesiologists and nurses. So we'll do weekly reviews on RDN patient selection. We are now currently selecting potential patients in our outpatient clinic as I would say, a department effort. A lot of physicians in our team, in our department, are now aware of this treatment option in our hospital, so they are constantly referring potential patients to the RDN group in our department. So maybe after or within the procedure, we will do continuous patient education and hypertension management, including lifestyle management with the patient. These are the key messages. Diagnostic evaluation for hypertension is, of course, crucial for RDN patient selection. as well as the feasibility assessment of the patient anatomy. You will certainly need a multidisciplinary team to diagnose and to select the right patient to offer the RDN. So this the case from our department. I hope everyone has enjoyed or take some message from this case. Thank you.
Okay. Okay, thank you. Thank you very much for the excellent presentation. So in this case, hypertension was cured, so you don't need any medication anymore. So in this case discussion, actually, we focus on patient considerations. So I would invite Professor Yu and Professor Li to give their comments on this case, and mainly focusing on patient considerations. So I would first invite Professor Yu from Lanzhou University, northeast western part of China. Please, Professor Yu.
This is a very amazing case, and actually I enjoyed so much. This is a young woman and suffer with hypertension and also have anxiety. I think she actually is, the mechanism is sympathetic nervous system. So we choose the team discuss about this case, and then make the decision of RDN, and finally gets a wonderful result. That's amazing. Thank you.
Yeah, Professor Li from Taiwan.
I'm from. Do you hear me? Okay. First of all, I would like to congratulate, because this is a very successful case. But actually, in our experience, it only takes about 10 to 20% to be like that. So we still have to emphasize that there is still some cases not respond so well. So if you are going to talking about the right patient selection, so far we would like to suggest that in the terms of appropriate, because so far we don't know which patients will be 100% to respond to renal denervation. And here is the slide. Maybe you can see that. As I know, this is so far the indication for renal denervation in China. And in Taiwan, despite different healthcare system, but actually we also has a similar recommendation for this. Because in these scenarios, I think renal denervation will be more reasonable to use, or reasonable to kick off and discussion about this procedure. And first, you have to confirm the hypertension should be essential. If you have some reasons, or if you know there is some secondary cause, you have to treat it comprehensively. And in Taiwan, we don't emphasize renal denervation is a control indication to renal denervation, because you know hypertension is usually multifactorial. But at least you have to treat the existed or the known secondary cause comprehensively at the first step. And if the response is not so well, I think renal denervation could be applied to all of the potential targets. And the second, you can see here, we recommend maybe the resistant hypertension or difficult to treat hypertension is reasonable. But actually, the strongest evidence so far is drug naive or those with mild to moderate hypertension. So this is just based on reasonable. And the second is if the patient have existed damaged target organ, or the patient has higher cardiovascular risk. So you have to take your action aggressively. Renal denervation could be reasonable. And we also have some experience from our patients. Maybe they only take 1 or 2 pills. It's not so comfortable for physicians to do the procedure, but maybe because of their personality or work style. Like we have several tour guides. They were working in Paris for most of the time, but actually their reimbursement system is in Taiwan. So they insist to take this procedure. Even I refused them at the first time. But most of them are super responders. We don't know the causality. Maybe there are some confounding factors between tour guides, aggressive personality, and the neurogenic hypertension. We don't know, but they were actually super responders. So the patient's voice also taught me maybe what they were thinking, or they are the only one to know their compliance. So here I would like to also recommend patient's voice and the reality of drug intolerance or drug non-adherence is very important with regards to the use of renal denervation. So I also hope the whole world will keep accumulating the experience or the real-world experience to renal denervation.
Okay, thank you. Thank you very much. Then I would invite Professor Yu to discuss further.
That one, okay. Thank you so much for Professor Wang. And now it's my great honor to share the key findings of the Chinese PPI study since our team have been involved to this study. Chinese PPI study actually, just like this slide mentioned, is the Chinese patient, physician-patient preference investigations in this field. This study totally induced 996 physicians and more than 3,700 patients from China. Actually, this is one of the largest global investigations in the field of RDN so far. And firstly, this result showed that over 80% of Chinese patients are willing or potentially willing to participate to adopt this new therapy regardless of the number of the medication they take or the blood pressure levels. And the proportion significantly higher than those survey results from the Western Europe and the United States. Secondly, we found that 70% of physicians expect RDN to achieve blood pressure reduction of 10 to 30 millimeter mercury, whereas Chinese patients generally anticipate a more moderate reduction of just 5 to 20 millimeter mercury. This totally imbalanced. And thirdly, what kind of patient or what kind of reason the physicians prefer? And first, the physicians believe resistant hypertension is prevalent in their clinical practice. And then they believe that the RDN is safe. And also, they think the more patient acceptant the RDN, the last one, and the purpose or the aim to enhance blood pressure control, they think that is very important. And the blood pressure cannot meet the target, so they need more education, more medications. Meanwhile, the patients more receptive to RDN are those with stronger financial capacity, since nowadays the price is still higher in China. And the patient have the trust in their clinical doctors, and the patient experience more side effect of medications. And those kind of patients, they visit their doctors quite often, so they can get more information with new science and technology of this aspect. So in summary, this study highlights the critical role of tailored shared decision-making in the influence of physician and the patient considerations. And also, this study and will benefit our physicians use professional guidance for thorough communication with patients and help patients make suitable decisions when education, when evaluation the RDN by themselves. That is just a brief introduce the results of these studies. And this study also was selected as an e-poster of this conference. Thank you.
Okay, thank you very much, Professor Yu and also Professor Li for their discussions. The Chinese physicians and patients are presently ready to use this technology for the treatment of hypertension. So then I would invite Professor Xue to give the second case presentation. So in this part of the case presentation, we would mainly discuss about technical procedures. So please, Professor Xue. Professor Xue is from is from Beijing Tsinghua Chang'eng Hospital. So please start.
Oh, thank you. Dear colleagues, ladies and gentlemen, good afternoon. It's my honor to be here to show a case for everyone. I come from the Beijing Tsinghua Chang'eng University in China. It's far from here. So we managed hypertension is about 61 years old gentleman hypertensive emergency, and he has 17 years history of hypertension, and his risk factor include the grade 3 hypertension, type 2 diabetes, and dyslipidemia, and smoking a long time, carotid plaques which was confirmed by ultrasound, and as well as stroke about 1 year. Secondary hypertension was ruled out, including the renal artery stenosis, renal parenchymal hypertension, and hypertension of the endocrine causes, such as primary endostenosis and Cushing system. And also, despite taking the about 4 and cancer or the antihypertensive medications, but his ambulatory blood pressure, you can see from the screen, the pressure monitoring during the hospitalization was still uncontrolled, just as shown. And given poor price control despite good adherence, RDN is indicated for him to as a drug-resistant patient. According from the patient, a large number of patients in China are similar to this patient. So it's a large work to do. Besides, the patient has strong willingness for RDN, so we decided to go for assessment for the RDN treatment. But next, as we mentioned from previous report, assessment on the renal artery with CTA imaging is important and quite common in China practice. So I will go deeper to pre-imaging part. Also in our center, we will also from the CTA and the VRT to recommend is used for the evaluation on renal artery. Just as the CTA imaging show, there is no abnormal anatomy and or accessory renal artery from the patient. Outcome of the both renal artery is going down size distraction. Besides, the left renal artery looks a little tortuous and with significant diameter variation among the different segments. Based on the finding, the anatomy renal artery was eligible for RDN treatment. Besides, several planning can be preliminarily considered before the procedure. First planning, we must to choose the right device for the RDN. Since we know the renal nerve location around about the renal artery and the bronchus. Main and bronchus ablation should be completed, and there is no doubt that wiring technique can make the procedure much easier. So, choosing the RDN catheter, which can be compatible with the guidewire recommended, like the Simplicity spiral from the Medtronic. And its design of the one size fitting all from the 3 to 8 millimeter arteries can help to handle the variable from the left renal artery. For guiding catheter, curve is more important. It seems the AMA curve can better match the outcome of the renal artery, and the 6 French is enough for spiral catheter. Besides, the 0.014 extra supportive guidewire with non-hypertrophic coated and floppy tips is much preferred for the safety consideration, like the Thunder guidewire. And additional support device can be considered for backup, like the telescope guide. This patient will use the telescope extension catheters. So the purpose of pre-imaging is for not only renal artery, but also peripheral vessel, including the femoral access. CTA evaluation can be extended from the first or the secondary lumbar vertebral to the biliary femoral artery and the selection of optimal access route, ensuring no abnormal anomaly like the plaques and the calcification to avoid access complication. So this is very, very important we decide to the device. Even though we have planned a lot with the CTA, but the angiography of the aorta and the renal artery is the golden standard for the RDN treatment. So next we will share more how angiography during the procedure help to get the treatment. Now we have a treat or not planning to treat a region. From the select angiography of the renal artery is pretty aligned with what we found in the CTA. The right renal artery was relative straight, and his branch is relative uniform. So it was relative more operable due to his anatomic structure. The left renal was relative tortuous with more treatable branches. So based on the angiography, one planning to ablation of the branch vessel, how many branches we will treat? Please scan the QR code and make your choice. How are some options for you? Please. Okay, good. It's similar for me. Yes, good. Very. Everyone is good. As we know, Time is on? Okay. So the first one is select. As we know, the treatable renal artery is for simplicity spiral is all 3 to 8 millimeter vessels outside the proximal. Since the right 1A branches of right artery looks less than 3 millimeter, from my perspective, I will treat 2 branches for right. And the left renal artery is more tortuous with many branches, and it seems much larger, much huger, and makes a strange based on the current angiography. So what can we do to get much clearer angiography of the left renal artery? Also, we adjust the protection angle from AP to LAO and the cranial projection to get a better visualization of the branches. After that, we know more about the left renal nervus and plan to treat the 4 branches. And also, during the ablation, we studied the ablation from the distal to the proximal, which means treat branches at first and then main renal artery. Spiral catheter advantage in the artery alongside with guide wire, just like what we do in PCI, is very easy to use for everyone. Here are some tips and tricks for advanced for the tortoise anatomy, like the left artery in the case report. The branches was difficult to access. Since we will use the simplicity catheter for the case, we use the special tips shape of the spiral to reshape the wire and help to get the branches. And it's a little help. More tips we plan in the case, like use a telescope extension catheter as well as bottle wire technique with the metro catheter, but it's very rare in daily practice. With the support from the wiring technique, tips of spiral catheter and extension catheter, we successfully completed about 66 ablation points of the main and branch vessels from the renal artery, and the post-angiography showed no instant stenosis. And we can see the follow-up. After ablation, the patient is currently in the 3rd month as a follow-up. But in the early stage of the follow-up, especially the 1st month after RDN treat, we were very nervous. The blood pressure with the same medication and any lower. So it's a very, did not we hoped. But we know, and in his 3rd month follow-up, the patient average blood pressure dropped to the 116 over 69 milliham, and his heart rate improved too. So it's just from the spiral 18 clinical prime, we know that the blood pressure lowering will appear at an average about 2 or 3 months after RDN. So besides the medication or the burden of the as shown in the graph, the medication is reduced also. So from this patient, I would like to take a summary. For RDN treatment, pre-imaging evaluation is essential for device selection and ablation stage planning, as well as access evaluation. Meanwhile, angiography during the procedure is one of the most critical golden standards in confirmed ablation stage. We must organize that the simplicity spiral catheter is very easy to use for renal artery vessel, especially tortoise anatomy. This is my report, and any of your insight and suggestion are welcome. Thank you.
Thank you very much. Then I would invite Professor Zhai and Professor Lu to give their comments on this case, and of course even further on the procedure, especially the technical aspects. So please start from Professor Zai.
Okay, thank you, Chairman, and thank you for a very impressive case of Dr. Xue just gave. I have a little comments about pre-operation imaging because I think I like CTO planning. Sometimes when do coronary intervention, the CTA is not very significantly widespread use, but unlike in that, in CTO, we emphasize the use of CTA to do pre-procedure planning because the complex, the anatomy is complex. So in renal artery anatomy, the anatomy is very differently, very significantly from very straightforward branches to very tortuous, very hard to explain branches from the main, sometimes very short to main artery. So we have to do the pre-operation imaging, and we have to consult your team, gather your team to discuss first of all, whether or not the anatomy is suitable for renal denervation, just with respect to the anatomy itself. And also, if we do renal denervation, how to do that? We have to devise how to do that, the strategy beforehand, both the denervation ablation sites and also what devices should we use. Sometimes we have to use very specific, very personalized guiding catheters, also microcatheters, dual lumen microcatheters, some also other types of guide wires to help with this very weird, sometimes very varied anatomy. So I think pre-operation imaging is essential. And also for the access site, sometimes we can see no atherosclerosis, but still very tortuous the access site is very unsuitable to go through the lower extremity. So at that time, we have to use the sometimes left brachial artery on very rare cases. So both on the anatomy variability of the renal artery system and also for access site, the pre-operation imaging is paramount. Thank you.
Okay, thank you very much. It means that you have to look at renal arteries. You also have to look at the arteries for the routing. So that's, of course, very important for the procedure. So then, Professor Lu.
Thank you, Professor Wang. I believe RDN procedure is not about device practice. We should take more about patient care into consideration. We just launched the conscientious about the RDN clinical pathway to provide more suggestion that. And I will share with you. For patients' preparation before procedure, the reasonable sedation and anesthesia plan should be consideration before surgery. It can ensure good experience to patient during the procedure. During the procedure, strict monitoring should be considered, including patient's vital signs, especially blood pressure and heart rate. Meanwhile, monitoring ablation parameter is also important when completing the mean and branch ablation. Like Simplicity G3 can have a clear display on temperature, impedance, and ablation time. Another key point, we should focus on the post-operative management. Single antiplatelet therapy should be started once procedure is completed and maintained for 4 weeks. Apart from that, closely monitoring patients' blood pressure change is also required in the 4 weeks and a long time. During this period, we need to optimize a patient's medication plan in time depending on patient situation. However, we should note that in the short term, it's better for maintain the medication plan consistent with the pre-operation regimen if not any urgency. Thank you.
Okay, thank you very much. So Professor Lu has been doing basic and clinical research on renal denervation in the past more than 10 years, and he recently published this China consensus document on the use of renal denervation in the management of hypertension. So you see, we have, working in this field and have some experiences both in research and in clinical practice in the use of this new technology for the future treatment of hypertension. So I thank Professor Lu, Professor Zai for the discussion on this case, and of course also Professor Xue for presenting this very interesting case. Actually, both cases are like a miracle. You see, we actually almost cured the disease. If we say hypertension is a disease, it was cured in the first case, and the second case also achieved the goal of treatment with the treatment and several medications. So we have discussed in the first case mainly patient considerations, and in the second case mainly those technical aspects of renal denervation. And spiral catheter was approved last year in China, so more than 100 hospitals have been using this catheter in renal denervation in patients with mainly resistant hypertension, also some difficult to treat hypertension because of poor adherence or because of poor tolerability. So here, actually, there are some questions, but we don't have much time. But I still want to have a 1 minute discussion on the technical aspect. Actually, the two questions are more or less the same about the procedure, when to stop the ablation or the renal denervation, because we need, of course, to do more research in this direction. But now we probably, your opinion, half minute, and your opinion, half minute.
Okay.
Professor Lee.
I think so far we don't have any endpoint to stop the procedure. So we just do our best to approach all of the spots ranging from 3 to 8 millimeter. But I think the most important part so far we know is the primary branch and the distal part of the the main trunk. So if you have some difficulty to approach some tortuous branches, I think you don't take too many risks for the procedure. But if you can, just do as many as you can.
Okay, very good. Thank you very much. Professor Zhai.
Thank you. I totally agree with what Dr. Lee said. I remember this case. I have conducted six cases. Usually it's 40 minutes, but this case 4.5 hours. Why? Because the renal artery system is like a spider. All of its branches are like very tortuosity. So I used guiding catheter. I used extension catheter. I used dual lumen catheter. I used Xiang wires and in exchange for the Sunder wire. All of my PCI strategies, I use them. So sometimes one aspect is really easy to ignore is the posterior branch. Sometimes we use the 0-0 the projection just plainly to show the arteries, but sometimes they are highly stressed. So we have to use different angles to expose the posterior side to ablate as many as possible.
Okay, thank you very much. So we reach the conclusions. So we have to choose the right patients and choose the right catheter And of course, we should prepare very carefully and follow up the patients also very intensively. You see, in both cases, and they watched very well the patients for a few months. Then they did several times ambulatory blood pressure monitoring to see the efficacy. So I think we just started, and we should do better. As Professor Lee and Professor said, we should do our best to ablate as many many branches as possible. So thank you very much for your participation, and so the session is closed. Thank you.